Thank you for joining everyone and welcome to our first webinar of our 22 male fertility series. My name's Eileen Regan, I'm the CCO at Examen, and it's my pleasure to invite you here this evening. So as many of you know, I think a lot of the names look familiar that are joining. So the webinars take place on a monthly basis, and we're joined each month by an expert in the field of fertility treatment or therapies. And it's open to all, so we enjoy a wide range of participants to join us, as well as the couples and individuals on their fertility journey. Just to say, the views of the presented in the webinars are the views of our speakers and not necessarily of the company. But you're all very, very welcome to join us. We're delighted to have you, and let me introduce you to our speakers. So today we're joined by Dr. John Kennedy, who is the Medical Director of Therapy Fertility. Dr. Kennedy trained and graduated from UCD. He's been a practicing obstetrician and gynecologist for over 20 years and has been working exclusively in fertility for the last 10. So he's worked at a number of different fertility units and was the medical director in Sims IVF from 2015 through to 2020. And in 2021, he joined and helped found a new clinic, Therapy Fertility, which is a new IVF clinic in Ireland promoting a more streamlined and accessible approach to fertility treatment. So Dr. Kennedy has been responsible for assisting thousands of Irish couples and women in becoming parents. And our chair this evening is Professor Sheena Lewis, who is the founder and CEO of Examen and Honorary Professor of Queen's University in Belfast, where for the past 25 years, she has dedicated her research into novel tests for male infertility. Professor Lewis is currently an executive member of the Association of the Reproductive and Clinical Scientists and chair of its Scientific Advisory Committee. She has published over 100 full papers, as well as numerous book chapters and reviews, and has been past chair of the British Andrology Society, UK National Representative and chair of the Andrology Special Interest Group of ESHRA, and executive member of the British Fertility Society. And she was also a founding member of vice chair of the Irish Fertility Society. Professor Lewis's research has led to the formation of the company Examen, where we market our exact range of male fertility tests powered by the sperm comma technology, which is now the market leader for sperm DNA testing in the UK and Ireland. So just before I pass over to Professor Lewis, I just wanted to run you through some housekeeping. So I'll pass over shortly to Professor Lewis for an introduction to Examen and to our speaker in some more detail on today's topic. And then over to Dr. Kennedy for the main event. And then at the end, we'll have time for Q&A. So please pose your questions through the Q&A panel. You'll see two buttons at the top, one for Q&A and one for chat. So if you could use the question and answer panel for the questions and use the chat then if you've any technical issues, and we'll do our best to help. So attendees will be muted throughout and videos enabled for the speakers only. All the events are recorded and we'll make these available on the events page of the Examen website, and they should be online by tomorrow afternoon. Also, 1 CPD point is awarded for all attendees for the 1 hour event, and give us a few days, but we will get the certificates circulated to you as soon as possible. At the very end of the session, we'll also invite you to rate the event, so please do so. We welcome all of your feedback in order to be able to continue these sessions and hopefully make them even better in the future. So without further ado, let me hand over to our chair, Professor Lewis, to start the session.
Good evening, everyone. Thank you very much for attending. Thank you very much for coming to talk to us and share with us in 2022. I know a number of you have already been here in 2021, and we're glad you enjoyed it so much that you have wanted to return. And believe you me, we've got a really exciting program of webinars for 2022 as well. So as Eileen has already said, we're going to be talking about what couples want. Now, in the past, as you know, we have had some pretty scientific and some pretty heavy medical ones, but we also, as a company which was founded within a university, are very interested in teaching. And so what we want to do tonight is to talk to a medical clinician, someone who has talked to thousands of patients. He was saying, just when we were chatting earlier on, that he's probably talked to 5,000 new couples in the last 10 years. So he knows exactly what people want, and he knows what they don't want. And hopefully tonight we're going to be able to drill down and see which is which. Now, I always begin by telling you what it is we're trying to do. Well, our mission and vision are to increase the awareness of male infertility. I think we're doing that. To provide men and of course their partners with knowledge and advanced testing, and to demonstrate that ICSI is not the solution to everything, that optimizing your sperm health first could even improve your ICSI outcomes and your health. So let's concentrate on that as well as treatment. Forgive me, I've got an awful croaky throat tonight, but apologies if it's a bit painful to listen to me. I'll be over in 5 minutes. We know that the semen analysis is really, really important. It's the gold standard and everybody should have that first, but it's not the only thing you need, because finding out what the count is, how many sperm you have, whether or not they can swim, whether or not they're good looking, that's not everything, because it's actually the DNA of the man's sperm that are going to make his children look and act like him. So that's really, really important. Over the last 12 years now, we've been around. We started off as a very small company based in the corner of a pathology lab in Queen's University. And over the years, we've expanded, and we now call ourselves a scale-up company, because we're doubling our staff, doubling our laboratory space, and we're planning new markets in the next year. So we're really going places. The exact tests have been based on over 30 years of research. This is all non-commercial research. This is stuff that was done in an academic university where there was no payment and no bias. These are the results straight from PhD students without any interpretation or bias from me. Why would you use Examen rather than use other tests? Because we know there are a few other tests out there. Well, we can diagnose male infertility more accurately than a semen analysis. We can predict the likelihood of fertility treatment success. The work, as I said, is based on many years of academic research. We've got excellent customer service, or so we're told. And we're the only people who can give you 3 results to tell you what your sperm DNA is like. We can tell you the average DNA damage across the whole semen sample. We can tell you how many good sperm you have, and we can tell you how many bad sperm you have. And because of that, and that's one of the main reasons that we're being used by 80% of the leading UK clinics in the private sector. And everything is done to the highest regulatory standards. We believe that exact testing is good for men because it helps them to take back control of their fertility. And I know Dr. Kennedy is going to talk a little bit about this tonight. It helps them to become equal players, not just the appendage to the woman. And it gives them a chance to improve their sperm quality. And that makes them more engaged in the treatment, because we know that men have been emasculated and neglected for too long. One of the wonderful things that's happened over the last couple of years is that a number of the major learned societies are starting to agree with us. And the European Association of Urology, the ESHRE, which is the European Human Reproduction, and the European Association of Urology as well, have all said that a semen analysis is the best thing you've got to do as a gold standard, but then you should really do other things as well. Because if you've got damaged sperm DNA, then that can lead to pregnancy failure and miscarriage. And the other thing that we're really glad to see is that the societies are now saying that the man ought to be evaluated by someone who can look after men, someone who's been trained in the male reproduction, and that's really important too. And then the icing on the cake for us last year was when the WHO manual, which is the gold standard right across the world, said, yes, we finally agree. We need to have an extended examination, including DNA fragmentation, because we understand as the global experts that there's a growing awareness that chromosome anomalies and gene mutations underlie a diverse spectrum of male infertility. So that's good enough for us, and we hope it's good enough for you. Well, tonight, I'm sure a lot of you have been reading and listening to what the HFEA has been saying about add-ons. I have to point out to you that these are add-ons to treatment. We are not an add-on. We are a diagnostic test. So we are not adding to people's treatments. We're just adding to the diagnosis of their fertility. So many tests are available, but which ones are evidence-based and which ones aren't? Which ones work and which ones don't? And that's what we know Dr. Kennedy is going to talk to you about tonight. There was a big conference at the beginning of the year called Fertility 2022. And one thing that we heard there was that couples want better tests for men. Now, if you think about it, the sperm adds 50%, the egg adds 50% to that lovely baby that people want. What do we do in the clinic? We give about 10% of our time to the men, and we give 90% of our time to the women and to their eggs. This has got to change. This is how we're going to improve our success rates. So tonight, Dr. John Kennedy is going to talk to you. And as I say, he is a man with much experience and also a sense of humor. And I am looking forward to hearing what he has to say. So we're going to hand over to you now, John, and the floor is yours.
Thank you very much. Now, let me... Good evening, everybody. First and foremost, I'd like to thank Examen. I'd like to thank Professor Lewis. I'd like to thank Eileen for the opportunity to talk to you this evening. I appreciate it, I really do. And thanks for the kind words as well, which are completely unfounded. So again, you've taken the time out of your evening, so I want to kind of try to keep this relevant, if at all I can. And I'd love to start a bit of a conversation going. So please, if you do have questions or thoughts, please ask them, and we'll get a bit of a conversation going at the end. Right, the title I got given, I didn't choose it, What Couples Want in Fertility Services in 2022. So look, you've heard a bit about my background already. I'm an obstetrician and gynecologist by trade. I qualified in 2000. I worked in obstetrics and gynecology exclusively pretty much for the next 12 years, then got into fertility in 2012, joined SIMS in 2013, became medical director in SIMS in 2015. SIMS IVF is an Irish-based chain of IVF clinics, and then left SIMS in 2020 and founded, along with some other people, Therapy Fertility in 2021. I've seen an awful lot of patients in that time. Now, I don't know if that makes me qualified on this subject at all, but as a middle-aged white man, I'm pretty much qualified to talk about everything, so I will. When I got the title of this talk, it put me in mind of this awful, god-awful film called What Women Want. It was a film starring Mel Gibson. I think it came out in the late 80s, early 90s, before his meltdown. And in this film, Mel Gibson learns to read the thoughts of women. He uses this initially for his personal gain and then eventually for personal growth. And tonight, I feel very much like Mel Gibson in this film, hopelessly unqualified to give out any kind of sensible or realistic advice to anybody, but it's not going to stop me. When I started in SIMS in 2013, I was made aware of some work that had been done on what were the three big markers of successful IVF clinics at that time. And I've written them there on the screen. And the order that they're listed on the screen, service, parking, and success, is in fact the order that they were rated. So the most important thing at that time to patients was the service they received. Not just in terms of feedback, in terms of conversation, in terms of information, and how they perceived the care they got. The second most important thing was, hilariously, parking. It shouldn't be important, but it is. And I really think that that illustrates the toll that fertility treatment can take on people on a very practical and granular level, and something we shouldn't lose sight of. And then the third was success. Now, if you don't know this and you ask people if you ask people in the field, what do you think patients want from fertility services? Well, the answer is very simple. They want a baby. They want a family. That's why they're there. But if you talk to patients and really start to explore that, that comes in not first place. Obviously, it's important. So what I want to do for the next little while, this isn't a particularly scientific talk. There's a tiny little bit of science at the end of it, but it's more about what my experiences have been in terms of caring for women, caring for couples, and a little bit about what we're trying to do here that speaks to that. And I kind of tried to break it into 4 areas. in the patient journey, if you'll forgive that word. The booking of a consult, the consult itself, the diagnostics that we do, and then the treatment, because these are the four big areas, and how patients interact with our clinics and what we do, I think is critically important. So, booking. If you think a little bit about how a patient winds up in a fertility clinic, well, it depends what jurisdiction they're coming from. In some centres, they'll go through their primary care pathway, they'll go to a GP, and they'll be referred to a fertility clinic from there. A referral letter, like this one here, will be sent to the fertility clinic. The fertility clinic will then reach out to the patient and book them in. But in Ireland, 70–80% of the time, that's not what happens. What happens is the patient self-refers into a fertility clinic. So how do they find out about the fertility clinic? Well, they Google it. That's what people are doing every day. They're Googling, how do I have a baby? They're Googling IVF clinics, and then they're getting onto a landing page on a website. But 9 times out of 10, that's what people are doing. I think it's what they're doing the world over as well. And even if they've been given a referral to a specific IVF clinic, they're still going to do that. So what happens at that point? What do patients want at that stage? Well, we have to look at this like you'd book any kind of appointment. How awkward is it? How difficult is it? If you pick up the phone and ring the clinic, will somebody answer? Will it be easy to book? If you try to book an online consult or book an appointment online, are you going to get bombarded? In the past, we used health questionnaires. We like our patients to give us as much medical information as we possibly can get before the consult, because it makes our lives easier. If they've had previous test results, if they've had previous treatment, we like the details of that before they come in, because again, that makes our lives easier. But we tend to forget that asking people for all this information right from the outset can be very, very harrowing. Clinics, some clinics, a lot of clinics maybe, tend to hold on to records a little bit longer than perhaps they should. Perhaps when you contact a clinic and you say, I'd like a copy of my notes, it takes 4 weeks, it takes 6 weeks, it takes 5 phone calls. You've got to hassle them to get your records. And so that can cause delays. Equally, I've worked in centres where we ask patients to fill essentially a 30-page health questionnaire, massively detailed, and it's overwhelming, and it's kind of unfair. So I would suggest trying to strip that back to the bare information that you can get away with is a nicer, kinder thing to do. You want to essentially learn how long they've been trying, what kind of things they're looking for, what they're expecting from the consult, and a little bit about medical history. If they can get their previous records, by all means, but you've got to make it easy for them to get. And also, I think you have to make it easy for us to read. We've had people show up with files that thick and show up on the day of consult and drop it into your lap. That's no good. It has to be given in advance, otherwise we don't have time to repair it. But giving them that information, trying to help them get the most out of the consult, I think is vital. You need to be able to do it over the phone, and you need to be able to do it online as well. Most people, it's 2 clicks. And if you can't do it in 2 or 3 clicks, people lose interest. Okay. COVID made a mess of things for us as well in terms of COVID questionnaires, but thankfully that's something that's fading away into the background, but it's another layer of aggravation. In terms of when they're booking, when is the appointment going to take place? How awkward is it to get to the clinic? How long can they reasonably expect it to be there? And what might happen on that day? Are they just going to see a doctor? Are they going to see a nurse? Are they going to see a patient coordinator? Are they going to have blood tests? Are they going to have a scan? And getting ahead of it mightn't always go that way, but getting ahead of that in terms of delivering that information to the patient before they ever attend will help manage their expectations in terms of what might happen. And specific to that is costs. So is the consult going to be charged? Is there going to be a fee? Or is it going to be free, but then you're going to get hit with a bunch of blood tests or something like that on the day, which people can feel a certain kind of way about if they haven't been forewarned. So I think the booking before they've even darkened your door is a very critical opportunity to demonstrate kind of the core values of what you're doing and how you're going to deliver services. So they've booked in, they've filled in their questionnaires. What's going to happen then? They're going to come in, they're going to have a consult. How long is that going to be? How long are you going to allocate for that? In the past, I gave an hour for an initial consult. We've changed a little bit. We're nurse-led here at this point. So a nurse is going to perform your initial consult, and they will have It's been blocked out as a 40-minute slot, but again, you're looking at the questionnaires before that, which does tend to speed up the process. And I think you can get a lot accomplished. The notion that you need to give more time and somehow more time is valuable, I can see where it's coming from, but I think you need to be very, very cautious about having consults that extend too long. Patients can only hear so much in a time. You've got an opportunity to maybe deliver 3 key clear messages. And personally, can't speak for anybody who's listening, but I know my attention span starts to tap out at about 20 to 25 minutes. No matter how focused I am, I need a break to stop and reset, and then I can refocus. So if I'm going to talk at you for an hour, I know that for 2/3 of that time, you're not going to hear what I'm going to say. Okay? If you're doing a consult, obviously the world has changed in the last 2 years. Is it going to be in person or is it going to be online? So what we found in therapy fertility over the last year that an awful lot of people were doing online consult. And it can be incredibly useful, and it can be incredibly engaging, and it can be very, very valuable, especially for people who are remote geographically. It can be incredibly beneficial. However, it would be my experience that an in-person consult is of more value, if at all possible. I know we're all wearing masks. I know we're living in that world still, maybe just for a little bit longer. But having them in and talking face to face, there's an awful lot of non-verbal communication that's lost over Zoom, that's lost over Teams or whatever media you're using. So I personally prefer in-person consults where possible, but I do think as an organization, patients want access to both. They also, in the past, I remember when I started doing a very early morning consult at 7:15 was my first initial consult, and it was easily the most popular consult slot of the week. No doubt about it. So early morning or late evening consults, so people don't have to take time off work, obviously very, very valuable. And by evening, I don't mean 5 or 6 o'clock. We all want that to be the evening, but you're talking about 7 and 8 o'clock. What should you be getting from giving people in the consult? Well, you want to give clear, concise, limited amounts of information. There's no point in spilling too much science into the conversation. Their eyes are going to glass over. This goes back to attention spans and simple messages. You need to impart a huge volume of very detailed, very complex information. Now, it's simple enough for us because we do this day in and day out, and we're repeating ourselves, and it becomes rote. You need to bear in mind, this is one of the biggest things that this woman or this couple will ever do. So you need to be respectful of that. And it's not just a 2 o'clock session for you, it's the culmination of years of heartache for them. So you need to be respectful of that in how you transmit information and what information you give them. You also need to back that up. You need to back it up with resources. When I finish a consult and I've done a treatment plan, that treatment plan gets posted online to the patient to read. It's a detailed précis of the conversation. Additionally, there are resources they can draw on from our website, from the community, from other players, which allow them to supplement and repeat the information that they've been given in the consult, and that's vital. There's a huge amount of information we give, which we give in a defensive fashion. We give it so we have defensibility. We give it so we can say, oh, you were told you might get ovarian torsion. You were told you might get no embryos. But you were told in a line in an hour-long consult where you had a massive information done. It's not fair. They need time to understand what this is for them specifically, and that speaks to consent, which I'll talk about, and in the generality. What are the broad things about cycles, and what about cycles are specific to me and my story and my needs. It helps enormously in the consult if you have the information already. So our model changed. We have a nurse-led consult in the initial phases. The nurses obviously have all worked in fertility extensively. They're very, very expert. They delivered the information as clearly and concisely as I have ever done, and probably more kindly as well, and with more compassion. It does mean that then when the testing is done, which is done under algorithm, but of course with conversation and with caveat on that, by the time they see me, I have everything. They've had a chance to peruse documentation. They've had a chance to access resources. So they're much more educated. It makes my job much easier, and it means they get an awful lot more out of them. So another take-home message there, getting that information, the more they know before they come in, the better off they are. So then we get into diagnostics and how diagnostics works. And when I was doing this, it put me in mind of this guy. I don't know, some of you may have heard of him. This guy, Ryan Stewart, is an American gynecologist. Was it December? Yeah, I thought it was November. In December 2021, he posted the following tweet: "I have the opportunity to design my office, his gynecological practice, from scratch. I'm asking women, how would you design, optimize a visit to the gynecologist's office? Problems, frustrations, solutions. No detail is too small." And then obviously he wanted it to go viral, so that's perfectly reasonable. It went viral. He got 3,500 replies, and the conversation went from simple right into the realm of the state of healthcare in America, which we don't have time to unpack tonight, but it did expose some interesting things. Some things were very, very obvious in terms of what we should be doing, and some were slightly less so. These are maybe the 8 or 9 top key takeaways that were there. There were many, many more, and it's worth a little kind of Google dive if you want to find out how that conversation went. Diversity in imagery, I think, and you have to bear in mind, this is gynecology, not necessarily fertility. It's not fertility facts, it's just gynecology. But that diversity in imagery very much spoke to me as what fertility services should be offering. And we need to completely move away from the view that fertility services are there to serve heterosexual, heteronormative couples who are struggling to have a baby together. That we're seeing a widening cohort of single women, people in female relationships, and members of the trans community, possibly pre-medication or post-medication, who are looking to explore fertility preservation options or even fertility options after transition. So that diversity in imagery speaks to the diversity and the expanding role that we have to play as fertility specialists in non-binary and non-heteronormative couples. Okay. Room 101, remove the TV from the waiting room. Nobody likes it. The day is over. Nobody wants magazines. Nobody wants a TV. We all have these little rectangles of knowledge in our hands now. So you don't need it. And it's you look at it and go, oh, that makes sense actually. Why do we have a TV in there? What should be on it? Is it distracting? Should it be there? People don't like paper gowns. Nobody's surprised with that. A gown that opens at the back, that's a little bit free to the air. Now, there's certain procedures you need to do that. But again, if you can just improve on the quality of that a little bit, you improve the patient experience enormously. Astonishingly, a number of people were asking for a changing room or a curtain while they got changed for an intimate gynecological exam. That's not surprising, and if you don't have that, you should get it. It was only today that I was talking to a patient who attended a clinic, I think in the Netherlands. She was from there a number of years back, and I did a scan on her and pulled the curtain and said, "You get changed, you let me know when you're ready. Well, and I'll come through." And she commented to me that she was very surprised that there was a curtain there, that she wasn't used to that. Now that seems to me to be dark ages stuff. This is very low hanging fruit, guys. Warm up the room, use different size speculums. This is real old white guy stuff. One speculum, one size does not fit all, especially if people are parous or have not had children already. A different size speculum can make an enormous difference. Offer painkillers, even if you think the procedure that you're doing or going to be doing is not going to be that painful. It's not your pain, it's their pain. So if you're doing something, let people know in advance. Listen, some people find this uncomfortable. You want to take some paracetamol, some Nurofen, what have you, before you come through, depending on cycle and timings, then that's something they can do. Two other little observations, which I think are very well worth noting, that patient really grinds people's gears. If you have a trainee with you, if you have an intern or a junior or somebody who's learning, people are very welcoming and very accommodating of letting somebody observe, but don't ask if the person can observe when that person is in the room. It's kind of a dick move, Barry. You know, it puts the patient under pressure to not say no. So ask them when the patient when the junior professional is not in the room. It's a kinder thing to do, and you'll still get yeses. And then finally, if you do have detail, while you're doing scans and doing procedures in somebody's wake, you can talk through your findings as you see it on the screen, and that's always a nice thing to do. But if there is detailed information to impart, imparted after the patient's dressed. Don't take out the probe and immediately while the poor woman is still sitting in the start chatting away. You have an opportunity to let them get dressed, sit down, and they'll thank you for it. And honestly, I felt that this is, as I said, low-hanging fruit. I think it's something at one time or other perhaps we've all been a little bit guilty of, and something that impacts far more on the patient than perhaps we realize. So back to it. When it comes to diagnostics, what do we want? We want to talk to people in terms of cost, and we want to make people very aware of what the cost of the various diagnostics are, how much they can expect to pay. You want accessibility to testing. You want timing. You want the consents to be clear. I'm going to talk a little bit more about consents when it comes to treatment. The most interesting thing about diagnostics, I think, that needs to change is the access to the results. They're not your results. They're not the clinic's results. They're the patient's results. So one of the things we've changed here is when we do patients have access to an electronic portal where they can look at medication calendars and their consent forms and their test results and all this. And as soon as we have the test result back, it goes up in their portal for them to see. So somebody can come in, have a nurse consult and have testing done, and those tests will be made available to them before they have a consult with me or a doctor or whoever. In the early phases, when we first opened, that created issues because people, imagine somebody would think, oh God, no, that'll create mayhem. Because people look at their results, look at their AMH is 4 or something like that, and they freak out and they're immediately on to you. So you need to get ahead of that. You need to say to people, as soon as your results are available, they will be made available to you because they are your results and we're not gatekeeping them. The interpretation and management of those results will be done as part of the medical consult. Now, and you can book that and you want to make sure that you have some availability for that. But as soon as you do that, then you get ahead of it and you'll get more buy-in. I guarantee it. It's critical that we do not gatekeep these results. People are entitled to their data. People are entitled to their results. The interpretation of those results, as I said, can be part of the medical consult and should be the purview of professionals in this space. So the next bit is treatment. So people don't talk about it. Cost, or they don't talk about it enough. Cost, financial cost, accessibility. And there's two ways of looking at this. The first is the base cost of fertility treatment, specifically treatments like IVF and ICSI, has historically been too damn high. It's been made very, very inaccessible. Certainly in Ireland, there's a whole bunch of people out there who want children, who want to do fertility treatment, who want to engage, who simply haven't been able to afford it. So one of the things we're doing is we're making it more accessible. There's two ways you can do that. The first is you can reduce the cost of your treatments, which I appreciate isn't a particularly popular move. The second is payment plans. When we started here for the first time, I'm working with a payment plan. And I would say about 30% of our patients are using it. Crazy. Looking at monthly repayments, it's third party, financial support. It's something, if you are offering fertility services, something you can get across the line, I would strongly advise you to look at. Your patients do want it. Okay. Consents. This is a huge issue. How do you consent something? What is the purpose of a consent? Is the consent a medical legal document they sign that absolves you of responsibility when and if something goes wrong? Or is it a live, ongoing process of informational exchange whereby the patient feels ownership and agency and comfort in what the organization is doing? Well, obviously it's the latter, but a lot of times we've acted like it's the former. And I think that consenting process is something that needs to be looked at very, very carefully and as a granular level going forward. Historically, we've all done this. As doctors, we've all stuck a consent into somebody's nose just before they go in under the knife and they sign it and they haven't a nod with their sign. They could be signing a power of attorney form, they could be signing a will. They don't know. Sign whatever's put in front of them, they haven't a clue. That's not good enough. And it's not enough just to give somebody a 36-page document and say, read that and sign that, and give them no time or opportunity to explore it. What we've done is we've tried to keep our consent forms short. They're 4 or 5 pages long, I think. And we've supplemented them with videos. Me and some of the other members of staff rattling on about various treatments, be it IVF, be it ICSI, be it IUI, be it donor sperm, be it reciprocal IVF, frozen embryo transfers, hycosi, hysteroscopy, the whole 9 yards. There's a different video for each one, and patients can peruse these at their own leisure, and it's a requirement that they watch the video before as part of the consenting process. Again, that's generic, it's not specific to them. So when consenting somebody, you need to have a broad conversation. Somebody who's 25 years old with PCOS is more at risk of ovarian torsion than somebody who's 43 years old with an AMH2. So you need to speak in terms of that. Equally, frozen embryo transfers are going to be, freeze-all cycles are going to be higher in some groups than others. If you're putting multiple embryos back in, then you need to speak to that. So you need to take the generic consent and then you need to supplement it with that. And you need to get this to people in advance of the cycle itself. You need to give people an opportunity to read, educate, come back. It's a call and recall system. It is a live, ongoing system. So it's not enough just to give them the consent form at the start of stims or on the day of egg collection or something. Appointments, people want to know their appointments are going to be on time. People want to know they aren't going to be late. People want to know how long an appointment is going to take. That's pretty obvious, and getting ahead of that saying, look, we tend, sometimes some days we run late, 10, 15 minutes late, they can build that in. You also want to get ahead of that and tell people not to be late, because that can be death for a busy list. I'm sure many of you know that. Partner attendance, especially in these weird times we have, has been a thing. We have partners in for early pregnancy scans, we have partners in for embryo transfers as well now. I think that's the right thing to do. But if you do have a policy on it, you need to be very clear and articulate in that. In terms of following up, post appointments, if somebody has had a scan, if they've had blood tests, how are you going to engage with them? How are you going to give them instructions? Are you going to do it with a phone call? Are you going to do it with an email? Do you have bespoke technology that will do this? You need a robust system for this. Telling them, not writing it down and not getting back up, that's not going to work. Okay? We tend to be slightly forgetful of our positive outcomes. Fire and forget, off you go, you come in for your early pregnancy scan and best of luck. Following up on these people, I think, is an act of kindness and shows you care. And I think we've all been familiar with the person who had a negative outcome, who's gone to another clinic and said, I had a negative pregnancy test. I didn't get another phone call from the clinic. I had a negative outcome. The only call I got was about money. I never got any follow-up. Now, sometimes you look back at those stories and go, oh no, they did try to ring and all the rest. You need to make the effort. You can't bombard people. They might want to be left alone. They might never want to see you again. That's fine. It doesn't always work out well. But you need to show that you care about the negatives. You know, you need to set that up. You need to have a robust system in place that stops patients from falling through the cracks when they've had an embryo transfer, they've done their own pregnancy test at home, and they haven't notified you. You can't just forget about them. It's not appropriate. It's not good medicine, and also it's not very nice. So, as I said, that is all profoundly unscientific and very opinion-based, perhaps not of any great value to any of you, so I'm sorry if that's the case. But I did find this. The common practices of the top performing IVF clinics in the USA is an article in Fertility and Sterility late last year. I'd advise you all to give it a peruse. This is what distinguishes the good clinics. They're using FSH and LH for stimulation. They're using IM progesterone in frozen transfer cycles. I also think subcutaneous progesterone works just as well. They're doing ultrasound guided transfers. They're doing a semen analysis before starting. And I would very, very much echo Professor Lewis's statements about male fertility testing. It is chronically underserved. It is not given nearly enough care and attention, and we're letting guys off the hook far too likely. Vitrification at the blastocyst stage, not day 2, not day 3. Good air handling unit, good gas filters, and then culturing in a low oxygen environment, preferably in a benchtop incubator. I think time lapse is great. I don't think it's great because of the extra information you get from it. Not yet, maybe that'll change. But I think it's great because it's a nice little incubator, nice little benchtop incubator, which keeps the embryos undisturbed. So these are the things that you can look at. Notably, the other stuff, receptivity and things like that, natural killer cell testing, got less, read the article, but got slightly less traction. So, man, I'm sorry, I'm running over. What are the take-home messages? Kiss, keep it simple, stupid. Simple processes. You can't be all things to all people. If you are, you're probably going to suck at a lot of it. So decide what you're going to deliver in terms of your, to be crass, product lines. Are you going to do IVF? Are you going to do ICSI? Are you going to do egg donation? Are you going to do sperm donation? Are you going to do reciprocal IVF? Are you going to do advanced receptivity testing? Are you going to do PGS? Are you going to do reciprocal IVF? Are you going to offer surrogacy? Are you going to run your own egg donation program? Are you offering freezing? And eventually you'll get too big. And what will happen is everything will start to suffer. The simpler and clearer your process lines are, I think the more successful you'll be, and the higher your success rate within that framework will be. I've been accused over the years of being direct, candid. Thank you for your candor. Sounds like a compliment, but actually it's not. I think you need to be transparent. I think you need to be very clear with patients about expectation management in terms of what a cycle can deliver. If you think their chances are low, you're not there to tell people what to want, but you're there to make sure they have a full understanding of what a 20% success live birth rate is, of what a 10% live birth rate is. Every single consult I do when I'm doing up a plan, they will get information, and part of that information will be in percentage points. I'm not saying I get it right, what I think their cumulative live birth rate will be from that cycle. Now, I think that's critical, because I think how we measure success in fertility treatment is often wildly unfair, because anything that's not a happy, healthy baby is pretty far short of success. So talking about biochemical rates, talking about implantation rates, talking about clinical pregnancy rates, that's all well and good, and it's great information to have. But for a patient, practically, they want to know what you think their chances of having a baby are at the end of this process. That can be a difficult number to give, and you can caveat it, but you need to give something. I think that's important. Costs, guys, the cheaper you can deliver care for, the better off you are. And then finally, it goes back hand in hand with the transparency, the expectational management, giving the patient agency and ownership, giving them oversight, trying to get what's in your head into theirs, so that whatever they decide to do is going to be the right thing to do. But of course, above all else, the most important thing is parking. And we've seen that still again today. So guys, thank you so much for your time and attention. I'd love if people had any questions, we can kind of get into it. No,
absolutely fantastic, John. Thank you so much. You said so many things, and so many of them, you know, you might have thought, well, those are common sense, but the problem is, as we all know, common sense is not so common, and so many of those things are just, they're absolute must-dos. Yeah. So I can't thank you enough for that. That was really, really helpful. Now, we do have a question here, and it's, someone would like to ask, how do you think bad news should be delivered to patients? Do you think there are different ways in which they should be delivered to men than women?
I think that's a great question. Look, breaking bad news, it's something, I'd love to say, oh, something all doctors are taught how to do. No, they're not. It's something we make up as we go along, and we try various different tactics, and we try to, we each have our own kind of approaches. I absolutely agree with you. I think it's very genderized, which is not right. I do think we have a tendency to be, perhaps if it's a male talking to a male, be a bit more abrupt and a bit more clinical and matter of fact, and then we try to be more compassionate or empathetic or supportive. If it's a male talking to a female, that's probably not helpful. I think there's some do's and don'ts when it comes to delivering bad news, and I think one of the most common things that we see in fertility is when you're doing a scan, an early obstetric scan, and it's not going well. How's the best way to deliver that? And I think early pregnancy units and maternity services and fertility clinics have struggled with this for years. For years, there is no really good way of doing it, because essentially you are going to be breaking news to a person while you have a transvaginal probe inserted into their vagina. It's tremendously uncomfortable. It's a tremendously intimate and horrific experience, and it's going to be one of the worst days of their lives. So how do you do that? I think it's not reasonable to not deliver the news at all, but I do think you want to keep it to a minimum. So I think if there is a playbook for how to break the news that a pregnancy scan isn't going well, it's while you're doing the scan to take your time. It's a very uncomfortable thing to do, but I think there's value in letting the silence fill the room, then explaining compassionately what you're seeing on the screen and why you don't think the news is good. Once you've delivered that, then you take the probe out, you let the person get dressed, you give them a minute, you offer them a drink, just give them a minute for the love of God, and then you have a conversation. And I've worked in early pregnancy assessment units, where the clinic has started at 7 and it's finished at 12:30, and there's 40 odd patients to be seen, and you're critically aware there's another 10 people out there and 30% of them are going to have miscarriages. And it's very, very easy to forget that this is the worst day of their lives, you know, and just giving them that time. I think the same goes when it's bad news with a pregnancy test, how you deliver that. When somebody's had a pregnancy, done a cycle, and they've come in, they maybe haven't done a pregnancy test at home, you've done a HCG, then we're going to call you with the results. That's fine. But you come, they could be at Tesco's, for God's sake, you know, and dropping that bomb on them is tough. So ask them how they want that news. Giving them, I mean, look, this goes to the core of the whole talk. What do patients want from fertility services? Ask them. It's real simple. Just ask them. Like, say to them, look, how do you want us to do? We can post to your portal, we can send you an email, we can give you a phone call. They'll tell you, and at least then they have ownership over how they receive that information. You know, so I think that's, I mean, it's not exhaustive. How should bad news be delivered compassionately and clearly, and given time, and then given time after the bad news? After, there's no point in having an immediate conversation. Well, you've had a negative HCG today, negative pregnancy test, right? We're going to talk about the next cycle right now. Of course, that's just silly. But a lot of patients will want to do that, and it's, I think, oftentimes you've got a responsibility. But look, I want to talk about that too. I just don't want to talk about it today. I'm not putting you on the long finger. I'm going to make time for you in the next 24, 48, 72 hours, whatever you need. Talk to you then. But it's just white noise. It's too much today. They need to grieve. Give them a chance. Give them a chance to that.
Yeah, well, I think that's both very, very sensible, but it's also very kind. I think that's one of the things that patients have said to me again and again, you know, the lack of compassion, just because everybody's in a rush all the time. But I do take the point entirely that you say the more patients know, or couples know, or consumers know before they go to the clinic, the better they are off. I know you're doing podcasts. Tell us a little bit about that. Do you think those are useful?
Yeah, I mean, like, I'm kind of the wrong person to ask. I just sit where I'm told to sit, and then I'm told, go, talk about this. Look, I'm very passionate about what I do. I always have been. So I'm really happy to talk all day. I'll talk for another hour on this. I'll give you an hour on ICSI without drawing breath. Now, I don't know if that's necessarily a good thing. What I have noted is, with the videos that we've made, with the podcasts we've done, with all the various social media that we've done, people who engage with that have a much easier ride of it going through treatment. Their expectations are better. They have an idea of what to expect. They find it better. Now, not everybody engages like that. Not like you just, that's not how it goes. But to have those resources there, it's really valuable for patients. I think it needs to be current. I think it needs to be relevant. I think it needs to be short and bite-sized. I don't know about the rest of you, but when I'm looking at a video on my phone, you got 30 seconds. You know, and if somebody doesn't fall over and make me laugh in 30 seconds, I'm moving on to the next thing. So you have to, you can't go and go and go. You've got to keep it. Honestly, there's real value in this for professionals. If you can't explain it clearly and concisely to a layperson, you probably don't know it well enough yourself.
Yeah, absolutely. There's one thing that I would like you to talk a little bit more about is online consultations, because I fully understand that has happened, you know, all through COVID. I mean, I've been singing from the hymn sheet that men ought to be examined, that, you know, if we only knew if they had varicoceles, if we only asked them much more about their lifestyle, their medications, etc., etc. And I just wonder if we're ever going to be able to have proper diagnostic workups for men and for women if we do it by Zoom.
Sheena, you've really landed on something there. And I mean, as I said, I qualified in 2000, and that's 20 years, which is a long time. But even if you go back to 2000, what we were being taught in college was clinical examination was key. Listening to the heart, listening to the lungs, tapping on the tummy, full examination, bimanual examination for women, where you were assessing the womb and looking for cysts and all this. That really appears now. I've been out of hospital medicine for a while, but it appears to be taking a massive backseat to imaging. And now imaging is the new god, and imaging and online consults. Now, I'm not saying, I think that's fine. I think imaging does a really great job, and I think it picks up stuff that clinical examination can miss. So that's potentially a progressive step, but we are losing clinical skills as a result. Let's not fool ourselves.
Yeah.
I look, for anybody who's listening who's been in this clinic, it's gorgeous. Like, it's genuinely, it's absolutely beautiful in here. And that for me is the extra man on the pitch. You know, I want people to come in. I want people to meet our staff, to get a flavor of it. I think it's very tough if you have an online consult, an online review, you get your test done locally, and the first time you come in here is a scan during stimulation. It's total deer in the headlights. And I know it's hassle, but you get so much more engagement with people when they come to your doorstep. But you have to offer online. That's the world, you know. But yeah. It's not as good. It's sad. But maybe I'm wrong. Maybe I'm wrong. I don't know.
No, but I absolutely take your point, and it's exactly our experiences as well as yours. I mean, I have said to couples, do you know that there are different success rates in different clinics in London? Are there? And I mean, as a scientist, that's the very first thing I'm drilling down to their detailed statistics. But I fully understand it's convenience. It's was the receptionist nice to me? Did she smile? Did she ask me how I was? And when I was on the telephone, did someone answer immediately? Those are the things that really, really matter to couples.
Yeah.
So we've got to realize just how important those are to, you know,
Now, I don't want to give the message. You need to be brilliant. Okay, you need to be brilliant at what you do as well. Like, get into this gig. You need to get success rates. That's how you'll get repeat custom. And that's like, you want to know how people find clinics. I mentioned Google earlier, but you know how they really find clinics? They talk to people. They talk to their friends. Who had a positive experience? Where did they go? Who was minded? Who was looked after? Who got a baby? Now, the very best way, I mean, that's how I built my reputation in this field, not by myself, but by making babies, by seeing a lot of people and getting a chunk of the break.
Absolutely. And I have to say, John, that's how we've built our reputation, in people telling people that they've got lovely staff and they talk to you and they listen to you, etc., etc., etc. I've just one last question, and this is about diagnostics and the interpretation. Now, it's an absolute breath of fresh air to hear you saying that patients own their results and not to be given them, and you're not actually, you know, like the solicitor who keeps all the money in the bank until he actually has to give it out. But one of the things that we find when we give our results, and ours are a very basic DNA test, to patients, they can get into an absolute tizzy because they don't understand the ranges of the results, etc. So do you think that just by telling them in advance, you know, we will interpret this with you, but we're just going to give them to you now, so, you know, for safekeeping until we then talk to you later? Do you think that's sufficient?
Well, for us, it was night and day when we started, because our messaging back when we first opened, going back to last year, wasn't clear enough that your results will be interpreted for you, you know, and that conversation will be had and it'll be okay, you know, and it genuinely created mayhem, and rightly so. It was our error, no question. So you can't be people. You need to be very, very clear, and you can't just say it. It needs to be in writing. When you do give these results, like, look at these guns. You need to put the caveats in there. Don't get too wedded to this, because, as you know, a DNA fragmentation is only one piece of the overall puzzle, and there's lots of, you know. I won't lie and tell you it works brilliantly. There are still a cohort of people who get very twitchy when they get a semen analysis that's OAT or a high DNA frag or a low AMH or something like that, and they're on to you. And you need to have a framework to deal with that, to pick up the phone or reply and go. But really, those people, what they really need to do is move their appointment up.
Yeah, okay, fair enough.
You know?
Yeah, well, I think that those are all the questions.
I also think that when you're giving out results, on something like a DNA frag, having some kind of information or some kind of resource that the person can draw on as part of your website, like, what is an AMH? What does it mean? Should I be worried? Should I not? A general overview, give them some information, what this means, and an interpretation comment does this, obviously, that can be understood by somebody who's not medical, is very, very important.
Yeah.
And I mean, even now I still see blood tests coming back, which I can barely read, you know? So what hope does the patient?
Yeah, I understand. Well, look, I would like to thank you, John. That was absolutely fantastic, most enlightening. And I'll pass you back to Eileen now.
Thank you very much, Dr. Kennedy, and Professor Lewis for an excellent talk. It was great to have you join us, and for everyone for joining. So thank you. Just before we wrap up, just to highlight a few things that are coming up. So our next webinar takes place next month on Tuesday, March the 1st, at the same time from 6 to 7 UK time. And next month, we're joined by Dr. Mary Samplaski, from Medical Director at the Director of Male Infertility, Andrology and Microsurgery at the University of Southern California. And she will be talking about drugs, prescription and recreational, and sperm. So a very interesting talk. We're very much looking forward to our first US speaker, second US speaker. We did have one last year. So yeah, it's a great honor to have someone from across the water joining us as well. So if you haven't already signed up, you can register online, and we'll be posting the subsequent speakers as well. So thank you again, everyone. It's been a pleasure to kick off the series with Dr. Kennedy. So please, if you want to find any more information, if you'd like some more information about Examen, the exact tests, or any of the webinar series, don't hesitate to reach out. You see the emails there to contact us, and we look forward to hopefully seeing you on March 1st for the next event. So thanks again, John. And
nice. Thank you. Thanks very much.
Enjoy the rest of your evening.
You too.